There we go. So in the past, we've done didactic sessions on adverse effects of clozapine, but we did have quite a few questions come up. So we broke out some of the more common ones. So this is our first session that's just dedicated to the sedation associated with clozapine. Our objectives for today, we're going to describe the prevalence of clozapine-associated sedation. So how often would you expect to see it? We're going to identify some pharmacologic actions that seem to contribute to sedation, and then we'll look at a little bit of evidence on the treatment strategies for how to address this in patients who are on clozapine. So let's start. I wanted to start first away with defining sedation. So it's interesting, the way that depending on where you look, there are varying percentages of how often clozapine causes sedation. Now, some of the reasons for that is the way that the data was captured. In some of the early clinical trials, there were a number of different adjectives that were used. So patients could report dizziness, tiredness, sedation, somnolence, and they all were reported separately. So depending on which one you look at, it may look like, well, if I thought it was sedation versus somebody else said, well, maybe I'm just fatigued or tired, it could alter those percentages quite a bit. We are using today that all-encompassing umbrella of all of them fit into this definition. The other definition that's been used more frequently recently is looking at the increased number of hours that a patient is sleeping per day. For this particular session, we're going to go with individuals who are sleeping at least 9 hours or more per day. And that's because of one of the trials that we're going to look at. That was the definition that they had used, thinking 9 hours is really thought to be a relatively healthy amount of sleep. And when we start pushing above that 9-hour mark, that may actually start interfering with activities that patients could engage in throughout the rest of the day. So how often would you see this in patients? So as I mentioned, that range is relatively large. So from 20% to at least documented over 65%, although there are some suggestions that it could be upwards of 70 to 80% when patients very first start taking clozapine. In a large majority of patients, tolerance can develop to this sedation within the first 4 to 6 weeks. So as they start taking it and we're slowly increasing the dose, the patients are able to get used to the sedation. Most of the dose tends to happen at bedtime, especially initially, and then they just can accommodate to it. The number of patients that don't develop a tolerance is also, there's some discrepancy in the reports. Some individuals say it's as low as 15%, whereas other estimates may be upwards of 2/3% or 2/3 of patients. So 66% of the patients on clozapine still have some degree of residual sedation. There was, so this was the trial I was teasing. There's a naturalistic trial that was done. It was carried out in a few different clinics in the UK. They had more than 450 patients who were on clozapine, and it was just an observational trial. They were looking at these individuals over a period of 2 years. And what they found was each of these patients were asked on a regular basis to self-report about how many hours are you sleeping every night. And about 65 of them reported that they're sleeping at least 9 hours or more every night. So the researchers then looked at a whole list of other potential factors that might potentially be related to, sorry about that, that might potentially be related to the amount of sleep that they're getting. Of the other pieces that they were looking at, the only thing that was correlated with the number of hours of sleep was their norclozapine levels. So the total clozapine dose, the actual clozapine serum concentration itself were not correlated. It didn't matter about age or alcohol use. There was no difference in gender, in tobacco use, in the amount of physical activity that they were reporting. So it really looked like for these patients, maybe the norclozapine level played a role, but they weren't able to as clearly identify, hey, these would be all the folks that were at risk for sedation, which they were hoping to be able to narrow down, but just weren't able to do so. So that introduces the question of what might potentially be going on that causes the sedation. So histamine plays a very prominent role in the sleep and wakefulness cycle. Specifically, we're going to focus on histamine 1. These are not copyrighted. These came from the Smart Art on there. There are some great graphics. Unfortunately, I wasn't able to find any that were uncopyrighted, so we had to somewhat recreate. So when histamine activates the histamine 1 receptor, it's a G protein coupled receptor. So we actually get activation of a number of different things. So phosphatidylinositol, as well as transcription factor. So CFOS, transcription factor, has been involved in quite a few different neuronal activities. So it is a marker of activated neurons. It mediates anything from extracellular signaling. It could increase the sensitivity of some of the receptors. It may also change this, the neuron's actual phenotype. So how it's responding to things and what it actually looks like in response to other stimuli. So it can play a pretty significant role. The results of activation of some of these things does seem to result in patients being awake and alert, feeling wakeful, and having what they call procognitive function. So really able to sit down and focus and concentrate on things. And I was looking for a good clip art, so something a little more positive in light of what's going on. So really being awake and ready to go. If we block that, so the thought is potentially the histamine 1 receptor antagonism may be somewhat responsible for the sedation. So clozapine itself is a relatively potent H1 antagonist, but interestingly, there's been some studies that are looking specifically at norclozapine levels, and it suggested that norclozapine may actually be a histamine 1 inverse agonist. So it's going to cause the opposite activity. So where antagonism may just block the activity of histamine and not allow for alertness or wakefulness, the norclozapine, being an inverse agonist, may actually promote sedation and sleepiness and the inability to really perform highly on some of the cognitive activities. So we're starting to lay the groundwork a little bit on what might be some potential treatment options. But first, is there a genetic role in all of this? So I was able to find a trial that was conducted just a couple years ago that looked at, I believe they evaluated 56 different polymorphisms to try to correlate, are any of these related to patients that are reporting sedation with clozapine. The short answer is no. So there were some trends, some polymorphisms that look like they may potentially be related, but the sample size was not large enough to give them statistical significance. So maybe there's something there. And the specific polymorphisms that they were looking at were a polymorphism in the histamine 1 receptor, which shouldn't be too much of a surprise. So if that's either less sensitive or potentially easier to be turned off, or it's not really activating those other secondary messengers, then maybe we're not going to see quite as much alertness and wakefulness, and that would increase the risk for sedation. The histamine N-methyltransferase is one of the, it's a metabolizing enzyme that actually can inactivate histamine. So if it tends to be a little bit more active or more efficient, and there's not enough histamine around to activate those H1 receptors, potentially that could increase the risk for sedation as well. That one had the strongest signal, and there were a number of different polymorphisms that they were looking at, but that one seemed to be the one that they thought would be most promising. The last one is the amine oxidase copper-containing 1. Excuse me. So this is also an enzyme that's involved in the degradation of histamine, not quite to the same extent as the methyltransferase, because this happens more in the periphery. So breaking down histamine in the periphery may not have as direct of an impact on sedation because it's those CNS H1 receptors that we're most worried about. So what they had concluded was, well, genetics may help explain the differences between individuals. None of them are going to be predictive at this point. So they are still doing investigations, but that doesn't seem to be the solution for why some patients have trouble with this. So recognizing it does tend to be prominent, it's going to stick around, what could we do about it? There are a number of different treatment options. These are the ones we're going to focus on today, with the decreasing clozapine dose and the aripiprazole being the primary focus. So in that trial that I was telling you about, the observational trial, there were 450 total clozapine patients, but they had enough data to evaluate information on 140 of them. They were in their mid to later 40s, and most of them they all had a diagnosis of schizophrenia or some type of schizophrenia spectrum disorder, and they had been sick for over 2 decades since their original diagnosis. So in these patients, they had about a third of them who were, over the span of those 2 years, were able to report that some of their sedation had decreased. So they weren't sleeping 9 hours or more on average every night. Of them, these were the 2 most prominent interventions that seemed to be related. So in 22 of the 140 patients, they had a clozapine dose reduction. So they did not give us what the baseline clozapine doses were, but on average, they were reducing the dose by about 45 milligrams. So maybe dropping the dose on average by about 50. And then in 23 of those patients, they were actually adding aripiprazole on board to the clozapine. And in this case, it was an average of about 7 milligrams of aripiprazole, although with the standard deviation, some of them may have been on 10 milligrams or more. What they found was in both of these groups, 4 patients actually reported that they had a reduction in the number of hours that they were sleeping. So instead of sleeping more than 9 hours a day, they were actually sleeping less than that. The average change, though, when they looked at all 22 or 23, was only about 0.4 hours. So a little less than essentially 20-minute change overall. But it suggested that there may have been some patients in each group that had a much more robust response. So for the patients that had the reduction in clozapine dose, the number that were reporting sedation decreased from 68% to 63 or 64% if you round up by the end of the 2-year mark. In the aripiprazole group, it actually went up. So about 70% were reporting initially, about 74% were reporting that they had sedation at the end, even though they were on the combination. But I did just want to point out, it is possible that there were some patients that were given aripiprazole that had a significant improvement, and then others that actually, maybe it made them more tired and did sedate them. So there may be some discrepancy within that group overall, that it wasn't really homogeneous. So potential options, there weren't really indicators or other confounders that would suggest who would respond best. If patients were well controlled, then clozapine dose reduction is suggested. If patients maybe still have some residual symptoms and the sedation is still problematic, then potentially the aripiprazole augmentation would be an option. For completeness, I wanted to include these 2 as well. So augmentation of fluvoxamine. So this would be the addition of fluvoxamine, the SSRI, but it's not necessarily added on board because of its pharmacologic action as much as because of its pharmacokinetic implications. So this tends to be added on board specifically to inhibit the metabolism of clozapine. So if clozapine isn't metabolized into norclozapine, it is suggested that maybe then we won't see some of the side effects, including the sedation. So there've been a couple small trials that have looked at this. One of the most well-controlled only had 18 patients. 18 patients, they were followed for about 6 weeks. They were stable on their clozapine dose and they added fluvoxamine 50 milligrams. Their target was to get the clozapine-norclozapine ratio over 2. They did not see any change in reported adverse effects. So no changes in weight, no changes in sedation, which they were hoping for both. They did, however, see a pretty significant improvement in the patient's psychiatric symptoms. So their BPRS scores actually dropped by more than 20 points on average. So theoretically, it may be beneficial. There are some case reports that suggest that this has helped, although that doesn't tend to be incredibly consistent. The last piece of potential treatment options are the addition of stimulant-type medications. So there have been case reports and case series of the addition of dextroamphetamine, methylphenidate, and levodopa being added to clozapine therapy in order to offset some of this sedative adverse effects. So the case reports do suggest that they're positive, although it's really difficult to tell without a controlled clinical trial how effective these really are, because the potential risk is also an increase in psychosis, because these are all dopaminergic agents. While patients who respond to clozapine maybe don't have a pure dopaminergic schizophrenia, it is possible that by increasing that tone, it could destabilize some of their psychotic symptoms. So that risk benefit isn't incredibly clear, but it is identified as a potential treatment option. So to wrap up, so we save time for discussion and cases. So sedation, incredibly common. You're likely to see it in anywhere from a quarter to more than 2/3 of patients who have clozapine. And while quite a few can develop tolerance in the first month to 6 weeks, if they continue to have symptoms, we may want to consider thinking about what else could be done. For persistent sedation, the two interventions right now that seem to have the best literature support are reducing the dose of clozapine if that's possible, or potentially augmenting with aripiprazole. If those aren't options, other potential interventions that could be done is the addition of fluvoxamine to inhibit the metabolism, or potentially adding a stimulant on board. And with that, I will turn it back over.
All right, thank you, Sarah, and welcome everybody to this edition of SZConsult called the Empress Edition, because on this day, April 7th, in the year 1141, Empress Matilda became the first female ruler of England. So there you go, Empress Day. I'm going to do this. In the interest of time, so we can save space for discussions and questions, I'm going to just ask people who are calling in by